etiology remains, as they say, unknown. And the accepted theory is that there is an abnormality in the basal ganglia or brainstem. That's another thing that we got to go into a little bit. But what about those that have traumatic injuries? Where does that come from? Some say after you have a traumatic injury and you start having the cervical dystonia, that it's in your head. It's all in your mind. It just is not true. That's what they tell you, right? But for you, it's true. One of the things that cervical dystonia, they found, Tolosa, in 1988, is that there's a hyperblink reflex in cervical dystonia. The vestibulo-ocular reflexes had an abnormality in it, which means your balance was supposed to be off, okay? This is one of the reasons why your head turns to the side. This is one of their research papers by Estelle. In 12% of the cases, after neck injury, those are the ones that develop cervical dystonia. And those that developed it because of trauma had less chance of correcting it with sensory tricks and less chance of having good treatment, or it was resistant to treatments later on. So what does the doctor do? He's going to go through a workup with you, right? There really is no test to confirm ST, and they go through a drug history, make sure that there's no specific drug that's causing it a problem. They make sure the age of the patient, and they take x-rays to see if there's any trauma, inflammation, or any congenital defects. Usually they don't find any. They take CT and MRI scans, which reveals most of the time that there isn't any. Okay, so what are the treatments? These are the conventional treatments. Take breaks. You take a break, it's going to help a little bit. Touch the other side of the face, the sensory trait. The oral medications, physical therapy, and the conventional one right now, the hot one, Botox. But Botox lasts about 3, maybe 4 months, and some people develop an antibody to it, so they can't take Botox. The other one, if they continue on, selective denervation, which is an irreversible neurosurgery, which means they're going to cut the nerve that supplies the neck a muscle. I like my neck. I don't like anybody cutting my neck. Okay, I hate going to the bar. Okay, much less. All right, and then deep brain stimulation, in which they stick 2 wires into your brain, and then feed the wires underneath your scalp, down your neck, into your, put in a big cigarette pack called a neurostimulator, and then it's supposed to decrease or get rid of the cervical dystonia. That's only something about 50 to 60. Or is there any other treatment? Is there anything else that can be done? Can we consider something else? Well, this is what you got to do. Think outside the box. That's what you got to do. You got to think outside the box. Because conventional treatments, you see how long they last. And sometimes when you think outside the box, there are things that are actually sitting there right on your face that you cannot see, but it's there. And once you remove it, there's a whole new universe that you can actually see. There's a whole set of worlds that you can actually now explore. And one of those worlds is dentistry. Dentists also have answers. It's been proven, as part of what you've just seen with Dr. Stack, is that movement disorders are very, are almost next to the stomatognathic system, or the movement disorders and the trigeminal nerve are very much intertwined with one another. I always say cranial nerve number 5, so I always go, what number? 5. That way you can't mess it up. How many? There you go, you can't mess it up. Cranial nerve number 5, the trigeminal nerve. The trigeminal nerve has three segments. It has the ophthalmic division, which is the eyes and up, the maxillary division, which is your mid-face, and then the largest one is actually your mandibular division, or the lower jaw. And it goes into these little, what they call nuclei, or little centers that are inside the brain stem. Dr. Hallett talked about that this morning, that there was an abnormality in the brain stem, yet they could not find any pathology in the brain. So here's what it looks like. The different segments that go into the brain stem, and then it crosses over and then goes up to the brain. And what we're going to focus on is this one little area called the spinal trigeminal nucleus. The trigeminal, or nucleus caudalis, is the same area where the trigeminal nerve actually interacts with 3 different nerves: the facial nerve, the glossopharyngeal nerve, and the vagus nerve. The facial nerve is for facial movement. Glossopharyngeal is the coughing and gagging reflex. And the vagus nerve is your voice box, or your tracheal muscles, and your heart and lungs also. Now, in normal neurology, or biology, we learn that each nerve has between 8 and 80 different connections. So the trigeminal nerve can have 8 different connections, or 80 different connections, to the facial nerve, or connection to the glossopharyngeal nerve, or to the vagus nerve. And when those nerves actually interact, it's called ephaptic crosstalk. So it's like turning on the light, and then all the lights go on down the hall. That's what ephaptic crosstalk is. But that's not what you really need to know. What you really need to know is that the trigeminal nerve, besides going into the 4 different nuclei, goes into an area in the brainstem called the reticular formation. The reticular formation is basically looks like a net, okay, a fishing net, and it goes all around and has many different functions. The many different functions are arousal, attention, cardiac reflexes, but the main one that you need to focus on, or the one that the cervical dystonia should focus on, is the motor functions. Because the motor functions are both voluntary and involuntary motor functions. So this is where it is. It's actually in the medulla, in the pons, and in the midbrain. And it courses all up and down the brain stem. But in the reticular formation, there are 4 zones. There's the raphe zone, which is in the very midline, the paramedian, which is right outside that one, the medial, which is right outside that one, and then the lateral, which is the most lateral. And nerves both go both upward and downward. That means they go up to the brain and down to the spinal cord. And here you can see the different collaterals, so they can actually interact with other nerves that go upward and downward. In the raphe, okay, the neurotransmitter is called serotonin. Serotonin is the main transmitter in this area. Remember I told you, about the study by Bihari, which said that obsessive compulsive disorder is more in those with cervical dystonia. When you have a decrease in the amount of serotonin, that means you have an increase in the amount of OCD. So what happens is, if you are stimulating that area of the reticular formation or those sets of nerves, constantly bombarding them, what's going to happen to the amount of serotonin? It's going to go down. What's going to happen to the OCD? It goes up. If you decrease or remove that input into the raphe, the serotonin will now come back to its normal levels. If it starts to come back to its normal levels, what's going to happen to the OCD? Go down. That's in the raphe. Remember that name, raphe. The paramedian zone is the area that controls the eye muscles. Okay? That's one of its jobs. The paramedian controls the eye muscles. Remember Dr. Jankovic's study said that in ticks and there is compression of that nerve. You can see there is compression of the nerve. You can see there is compression of the nerve. And this doesn't always happen instantaneously, as in whiplash or something like that. It can happen gradually over time. And it can be due to the imbalance in the occlusal imbalances and facial asymmetry. Now, I didn't talk about stress, but what happens when the person is stressed? A lot of people clench their teeth. Am I right? Yes. What happens to your cervical dystonia when you clench your teeth? It increases. It's on your paper right there by Dr. Hallett. Second paragraph, third line down. Stress increases your cervical dystonia.